Good morning, good afternoon, or good evening. Thank you very much to the organizers for inviting me to give this talk and for the introduction. I'd also like to beg their indulgence in that I changed the title of this talk from Pediatric Cardiology from a global healthcare perspective to Pediatric Cardiac Care from a global healthcare perspective. I come to you from Cape Town, South Africa. Unfortunately, I'm not with you in person, but I'd like to also acknowledge my affiliations, funders, collaborators, and team members. All patient photographs are with permission, but to start with, I have a few disclosures. I am unashamedly and proudly South African, but my continent is very complex. 36% of those living in the continent live on less than $1 a day, and we contain all of the world's 10 poorest countries. Africa has 0.1 doctor per 1,000 people, Europe 3.9, and more than 300 million births are unattended. We have more than 400 million children. This is estimated to increase to 2.4 billion by 2030, which will then constitute a quarter of the world's population. There are 27 million people living with HIV, and 35 million or more have already died. We have 1.2 billion inhabitants, 41% are less than 15, and 75% of the children in the world who live in extreme poverty live on our continent. 17 countries in the last decade have not had a census, and 5 countries have not had a census for the past 2 decades. We contain over half of the world's 5.4 million under 5 deaths. This was from 2017, and 32% of the children on the continent are 2 or 1 parent orphans. 31 million children will die in the next decade if the Sustainable Development Goal of less than 5 mortality rate is not achieved. My other disclosure is that I'm a rheumatic heart disease researcher. Rheumatic heart disease is often called a barometer of social injustice and inequity. It is where sore throat, treatable by a simple antibiotic, becomes a death sentence, virtually eradicated from high-income countries and still reigning rampant in low and middle-income countries in the world. But I'm here to talk about global health. What is global health? It is an area for study, for research, and for practice that places a priority on improving health and achieving equity in health for all people, worldwide and from an interdisciplinary perspective. There is no us and them in global health. It is meant to emphasize people worldwide and move from population-based prevention to individual-level clinical care. However, if you look at 198 organizations across the globe that maintain that global health is their vision or their mission, it is interesting to see where they are located. 38% in North America, 46% in Europe, but only 1.5% in Latin America or in the Middle East. Global health is increasingly popular as a new field of study. It includes an urgent social concern and a powerful interdisciplinary intellectual synthesis. It is aimed at understanding and productively intervening in the processes of healing, of illness, but also of health. And this is across the globe, now even more than ever. It's always important to remember that equality is not the same as equity. And we have focused this year on health equity and its determinants. and reminded ourselves once again that it is time to build a fairer and healthier world for everyone, everywhere. And there's no better place to start than the Sustainable Development Goals, and in particular, the Sustainable Development Goals as it applies to children, because really starting with children is probably the only way to achieve these. It's important to note that every child needs nutritious food, health care, shelter, social protection, safe drinking water, and decent sanitation in order to survive, to develop, and to thrive. If we look at the Sustainable Development Goal 1, that is absolute poverty, we can see, if you look at the world mapper depiction of the world in terms of those living with absolute poverty, that North America, Europe, Australia disappear. If we position pediatric cardiac care within our world, this is from the Invisible Child series from Children's HeartLink, there are probably 4 major areas to review: measurement, advocacy, policy change, and then specific goals. And I hope to address these in the next 15 to 20 minutes. Look at congenital heart disease prevalence around the world. There's a very stark difference between, for example, Asia at 9.3 per thousand live births and Africa 1.9 per thousand live births. Is there really a difference in terms of prevalence? Do we simply not have the same amount of congenital heart disease in Africa? We need to now look at these data with somewhat more granularity. This is from a more recent meta-analysis from 2019, where the numbers had increased somewhat to 2.3, but it still put the continent of Africa in the 1940s. If we have a little closer look, we can see that the prevalence of overall congenital heart disease has steadily been increasing over the last 50 years. But what has been steadily decreasing, even more dramatically so, has been under-recognized congenital heart disease. This is the case all over the world, except in Africa. This is the global prevalence of congenital heart disease in school-age children. And you can see this dramatic increase over the last 10 or 15 years in Africa. So what this actually is a story not that we don't see congenital heart disease in Africa, but it is a story of diagnostics, of prevention, of availability of echo, primary health care, and the lack of trained workforce. I don't have sufficient time today to go through the status and challenges of care in Africa and other low and middle income areas in terms of adults with congenital heart disease, but you can well imagine there are specific issues and similar themes. This is the global burden of rheumatic heart disease, and this again shows those trends. What is happening to the age standardized prevalence? You see all the way from a 20% decrease, for example, in the US, to a 20% increase in the Democratic Republic of Congo. Another important trend is what is happening to the cause of death in children under 5. In 2013, one could see the band. This is congenital anomalies in the orange band. In developing countries was number 4 on the list. In developed countries, on top of that, you could see it was a top cause of death under the age of 5, knowing that that was almost primarily constituted with mortality from congenital heart disease. If we look at 2017, you see overall congenital birth defects or mortality related to congenital defects has cumulatively dropped down to number 5. But when you apply the global health perspective, you look at the causes of death above that: lower respiratory tract infections, neonatal preterm complications, diarrheal disease, neonatal asphyxia, and trauma. And consider how those affect the patients that potentially also have congenital heart defects. And consider how we can attack and intervene in those 4 major causes of death. If we look at rheumatic heart disease, it's so clear which parts of the world are endemic and which parts of the world are non-endemic. This gives you a very global approach, but if you look very regional or even country approach, you can again see a different story. This is Australia. The incidence rate of acute rheumatic fever is approximately 53 cases per 100,000 in Indigenous people, less than 1 case for those that are non-Indigenous. But Indigenous people are more than 8 times likely to be hospitalized for acute rheumatic fever and rheumatic heart disease, and 20 times more likely to die. Remember, global health emphasizes people worldwide, looking at population-based prevention with individual-level clinical care. When we look at, again, rheumatic heart disease, the graph here on our left-hand side looks at penicillin shortage, which was particularly prevalent in about 2016 to 2018. And here you can see it's not a low-income country versus high-income country problem. It is not even a regional problem if you look at Africa versus South America. But different countries experienced different levels of shortages. And this is also something that we have to focus very clearly on. Is this a question of supply? Is it a question of demand? Is it a question of sharing? How do we disseminate such important and essential medicines? Then again, when we look at evidence-based programs and personalized care, again, we have to apply our global health lens. How many cardiac catheterization laboratories do we have in that particular region? Do we have adequate supplies of drugs that are essential, such as warfarin or penicillin? How do we approach cardio-obstetric care? How do we integrate this? And do we have sufficient echo machines in this particular region, or the type of expertise that we need for fetal echocardiography? And pharmacological treatment of heart failure differs dramatically from one country to the next, related to what is essential medicines and what is available in private or in public healthcare. Evidence-based medicine programs rely on evidence. We need to strengthen global health research capacity, especially around pediatric cardiac care. And we have to do so even more in low and middle income countries, where the research that is required is even more urgent. It is also very important to realize, now more so than ever, that diversity in research is important, and the lack of diversity is being more and more discussed. These are the 100 most influential articles in congenital heart disease for the last 20 years. And it's interesting to think and review these critically. How many of these come from low and middle income countries? How many come from emerging or growing programs? How many truly represents collaboration and group efforts? How many are coming from high-income countries, high-volume units with established researchers? This is a study from PLOS looking at the global research collaboration of network meta-analyses. For those of you who understand a network meta-analysis, you know that these nodes represent the amount of participants, and the linkages represent the amount of studies. And you can see that more authors, institutions, and different countries are becoming involved in research collaborations. But the concern is that it still is limited International collaborations are limited, and they still revolve around the three major nodes: the UK, the USA, and Europe. We also are so aware of the fact that planning a health program without high quality information to inform that program, to drive decision making, is like trying to finish a puzzle with only a few pieces. We need actually to start building together partnerships with academia, with industry, with government, the non-profit sector, and international organizations to be able to develop innovative institutions and solutions. Often this is thought to be just too complicated in low and middle income countries, too complex, too expensive, but actually it offers the greatest potential rewards. Big data era, for example, can represent a major and beneficial turning point in the improvement of global health. It is time to move quite rapidly away from paper records to digital storage. And this gives us another opportunity to accelerate events within the global health agenda. One of the areas that we talk about often is health advocacy. There are two major goals that underpin health advocacy. That's protection of the vulnerable and empowerment of the disadvantaged, representational and facilitational advocacy, but always putting the patient in the middle. We know that patient engagement in clinical decision making and in research should be encouraged. There should be a partnership between clinicians, scientists, and people with a lived experience of the disease. And we also know that patient engagement in research has been shown to lead to more impactful and relevant findings. And this applies in low and middle income countries as much as in high income countries. In fact, even more so, where these partnerships and working together with the patient and family communities can lead to patient mobilization, leveraging partnerships for financial support, peer-to-peer mentorship and psychosocial support, and education of patients and the non-patient community. We have developed a program called Listen to My Heart, where we spend several days over a period of years going through and encouraging patient-led wellness workshops where patients can speak to each other about various health and wellness issues. Global Arch, which is the Global Alliance for Rheumatic and Congenital Hearts, have developed a rights declaration for children with heart disease. And each year we celebrate World Heart Day. Last year, there were over 1.3 billion interactions across the 29th of September. What is important about days like this is that it reminds us that we are interconnected, that we are a global cardiovascular community, where we have very much similar problems and concerns, but also opportunities. The logo here is around digital health and how we can use our heart to be more connected. We know that being disconnected is a sign of being more vulnerable. And the gap in prevention, diagnosis, and treatment has been due to the lack of access. But a gap in social connectivity, we know, is a known risk for cardiovascular disease. The LANCET Commission recently published their findings on non-communicable diseases and injuries linked to poverty, and focused on the fact that it was not a gesture of charity to overcome these, but rather an act of justice. We know, regardless of what will happen with COVID, that the NCD burden will increase over the next 10 years, globally by about 17%, but in the African region by 27%. And 2 billion people, many of them children with congenital and acquired heart disease, will not have access to essential medicines for their conditions. But children with heart disease can be a battering ram for NCDs because the cornerstone to prevention of NCDs is a life course approach. Childhood offers a golden opportunity for cost-effective prevention of NCDs, and there are cost-effective interventions that can be delivered through basic services such as vaccination and can prevent death and disability. We know that the 4 key risk factors have special application in children. Those with those risk factors have special impact upon their children. And it's up to us to uphold the UN Convention on the Rights of a Child. We know this is critically important because children that are born with congenital heart disease are more likely to develop stroke, heart failure, and coronary artery disease in the future. Hence, the approach to non-communicable diseases should start in childhood. We also know that robust clinical research, collaborative clinical research, even more so, can have impact upon outcomes. This is the REMEDY study that was a rheumatic heart disease study from 25 centers in 14 countries across Africa, India, and Yemen. Some of the investigators are pictured there in Addis Ababa. And the results of the study, which showed that over 27 months, with a median age of 26, 16.9% of the patients died before the end of the study. That we were able to show that and therefore lead strongly onto the global resolution for rheumatic fever and rheumatic heart disease that was adopted at the 71st World Health Assembly. In 2017, the CDC published their 10 global priorities for global health. And it's so interesting that the first one was around remaining vigilant and prepared to identify and respond to global health threats. In 2021, however, we're talking about global vaccine apartheid in the wake of COVID-19. COVID-19 has not been an equal opportunity virus. It goes after people in poor health. And so it's disproportionately affected the poor, the vulnerable, those who live in fragile health systems, and those that live in areas in advanced economies that do not have access to healthcare. And we've seen this very clearly in the United States and the United Kingdom. We need to increase screening and diagnostic tests so that we can detect disease early and accelerate our response. The amazing success story of newborn screening that has now been adopted in many, many countries and almost all of the regions of the world. These are 2 other success stories. The one comes from Kerala in India, where they looked at the impact of transport on arrival status and outcomes of newborns with heart disease, and noting that if they had to transport a patient, they generally did worse than if they were born in hospital with a critical congenital heart disease, leading to a widespread fetal program. In Brazil, they developed a very comprehensive center of telemedicine across northeast Brazil, and they were able to utilize this in 2020 to accelerate treatment and diagnosis even during the COVID period. We need to look at how we build a health workforce. This is again focusing on some of the countries in the continent. And we know that we often talk about one pediatric cardiologist for 500,000 population. In these countries, it would mean these kind of numbers. Let's see what we really have. In Nigeria, there are 5 public service pediatric units. In Uganda, there is just 1. In Algeria, 8. Sudan, 4. And in South Africa, 8. If we look at the workforce, and this time we're only looking at pediatric cardiologists, there are 33 in Nigeria, less than 10% of what is required. In Uganda, 3, even less. Algeria, just less than 10, Sudan, 7, and in South Africa, 24. So we need to strengthen the health workforce to be able to strengthen the health system. Africa has got 17% of the world's population, 26% of the global health burden, but only 3% of the global health workforce, and spends less than 1% of the financial resources in health. There's thought to be an 18 million doctor, nurse, and midwife shortage to be able to achieve universal health coverage by 2030 in low and middle income countries. This is the Cape Town Declaration on Access to Cardiac Surgery in the Developing World, and in the accompanying editorial talking about global unmet needs in cardiac surgery, we were able to show that there is 11.5 cardiac surgeons per million population in Germany, for example, and 0.06 in Nigeria. When we talk about the health workforce, we're not only talking about doctors and nurses. Community health workers are often the first to identify life-threatening illnesses. This is from Rwanda's community health program, depicted on the right, India and Zambia. Not only do we have to think about increasing the health workforce, but we have to build in quality improvement programs. This is CathChat, which is an initiative based in my hospital to improve pediatric interventional cardiac catheterizations. And I think you all know the IQIC collaborative for congenital heart disease surgery. What are some of the approaches that we can take? Firstly, disruptive health solutions. Medical drones from Rwanda. Portable ECG machines from rural India. Kenyan telemedicine kiosks, off-road wheelchairs, diagnosing the cause of diarrhea in Botswana, and Burkina Faso's district health information system. What's important about all of these is that they've been adopted in the West. So the direction should be not only from high income to low, but also from low income to high. These are some of the trends impacting the global digital health sector. We know that, for example, in Africa, there's more than 50% uptake of mobile technology. We need more support for human-centered care and cost-saving solutions. We also have to think very differently about financing. We have to consider things like blended capital, integrated sectors, and concentrated impact. We know that a good health system requires disease monitoring systems, outreach, delivery services, along with accessible and high quality primary care. Improving population health also demands improvement in vaccination rates and better preventative programs such as maternal and child health. Improved social circumstances that can affect health, such as safe housing, quality educational opportunities, and solid job prospects need to be considered. And if we want to focus our attention at any particular set, it would be on the most vulnerable, women and children. Universal health coverage should be of good quality, should be timely, acceptable, affordable, and appropriate. And there have been multiple resolutions along the timeline to be able to strengthen this. In 2019, the UN convened a high-level meeting on universal health coverage in New York, moving together to build a better world. But we have to be aware of the threats to global health, internal and external. External, hoping to help, the promises and pitfalls of global health volunteering. The issue of safari surgery, for example, has been one that has been part of our community for some time. From internal point of view, there are many crises associated with global healthcare, from prohibitively high healthcare costs, shortages of physicians and medical staff, to lack of health systems, as well as lack of healthcare infrastructure. This is the elephant in the room. How do we address these power asymmetries that exist within global health and that were made so clear in the wake of COVID-19? So I'm going to end by what we can do.
Be critical of data. Consider the context, the region, the source. Ask for the trends. Review the granularity of the data sources. Be a careful reviewer of grants, papers, and opinion pieces. Consider the local ownership and who is the power within the paper. Link units. Build diverse collaborations and groups. These don't have to be between North and South. They can be across units. They can be interdisciplinary. They certainly can be across regions. Ensure capacity building and local expertise with sustainability and independence. How can you build? How can you impact? How can you empower beyond your borders? And innovate, disrupt, and transform. But our collective goal should be health equity for all. Pediatric cardiac care can be an exemplar for global health. Exploration of the social determinants of health and applied epidemiology is crucial to understanding patterns of disease and responding decisively. All children with heart disease deserve equitable access to quality health care. Thank you very much for your attention and for the honor of allowing me to deliver this lecture.